Today we have once again for the last time Dr. Mayur Khairnar, but not the least, Dr. Mayur Khairnar from India with us. So those who don't know about him, let me introduce him that he has completed his BDS and MDS in periodontology and implantology. He is also a fellow and diplomate of ICOI and currently pursuing PhD in dental implants. And with over 26,000 successful dental implant placement, he specializes in graftless immediate loading solutions. Moreover, there are many international publications and multiple patents to his credit and has conducted clinical workshops and trained clinicians globally. Dr. Khairnar is a pioneer in advanced techniques including engagement of implants in pterygoid, zygoma, nasal floor and lingual cortical with biocortical engagement. The QuickDent company is designed to overcome the complications and offer graftless solution with a lifetime warranty and durability. So today I welcome you all to our special webinar on this momentous occasion that is India's Republic Day. Republic Day reminds us of the importance of building a healthier and a stronger nation. And oral health plays a key role in achieving that vision. Just as the Constitution of India serves as the backbone of our democracy, oral health forms the foundation of our overall health. So now without any delay, let's talk about the topic of today's session, that is decoding digital and analog method to master full mouth reconstruction with immediate loading. So basically this full mouth construction is more than just a procedure. It's a transformative process that restores not only oral functionality but also the confidence and quality of life for our patients. So throughout this session, we will break down into the role of the digital workflows in planning and executing reconstruction with unparalleled accuracy, the value of analog techniques in complementing digital processes for customized solutions, key strategies and tips for achieving clinical success with immediate loading protocols. So get ready to decode the secrets to mastering full mouth reconstruction. Before we begin our session, let us remember the ethos of Republic Day, participation and collective growth. Feel free to ask questions and share your thoughts with our speaker throughout the webinar. So all over to you, Dr. Mayur. Let's begin.
Thank you so much, Dr. Shriya, for the wonderful introduction. And first of all, happy Republic Day to all of you. I will be sharing the slides shortly. So very good afternoon to all of you. On the day of this Republic Day, I'm very grateful that I got a chance to give you an idea about the digital and analog method. So first of all, I would like to understand how many of you feel we should have such kind of results in our day-to-day practice. You can just observe the before and after of the patients. There has been a tremendous change in their smile, their the confidence, their energy level, everything. How many of you believe that? Okay, you can put down yes into the comment box. I'll be able to see that, right? So in order to do that, after doing this, there is also one more good benefit which all the patients go through is that they are in a situation to chew well. They could eat well, especially those patients who are having totally missing teeth or all their teeth are loose or they are flunging around. So my friend, how many of you believe that if we should make such kind of changes in people's life? Great. So suppose a patient comes to you like this. Okay, you can see the x-rays, see the confidence and energy level, see our x-rays. She is like totally, the bone is atrophied, there is a lot of bone deficiency. It's not easy to restore such case. However good surgery you do, you do any heroic surgery, you do zygoma, you do quad zygoma, you do nerve bypass, whatever you do, okay, but if what is patient is more interested in? Patient is more interested in the final outcome. Am I right? Are you getting it? You do wonderful surgery and you give a pathetic outcome. Will the patient will be happy ever? No. So it has to be the patient-centered outcome. That means the patient should be finally very happy. No, and whatever treatment you do should be at 100%. That doesn't mean that you will do a wrong surgical procedures and you give excellent results. It should be long, durable as well. So patient is not interested in what you are doing inside her. Patient is interested in what she or he is going to get after the treatment. Okay. Now you can see what kind of transformation is done in this kind of this girl, young girl, and this is done that too in 3 to 5 days, because she could eat well. She is smiling good, and look at her confidence level before and after. But my friend, is that so easy? No. This patient has to go through certain steps and processes, okay, so that we get this result. Okay, so it's not that, so I come across many doctors asking me questions, which lab you are giving the work. Okay, so it's not about the lab. Of course, it's a one part, but it's about what information you give to the lab, so that lab can design and fabricate the process according to your precise information. It is the dual thing. Lab have to replicate your information, whatever you're giving to them, and at the same time you should give an accurate information, because you are a mediator between the patient and the laboratory, so that you can get a desirable result. So such patient have to undergo a different set of processes. Okay, so today in this webinar I will be emphasizing on how you can do the transformation prosthetically or surgically, with a digital method as well as analog method. What is analog method? Is the conventional method where digital components is rarely used. And what is digital method is where we, today, nowadays, you will see a lot of digital things are happening. So I'll show you both the method. I'll compare and we'll come to certain conclusion, which is best or which is not best, whatever it is. Okay. So let's me start with one case. So here, this female was having totally periodontally compromised dentition. See, in fact, her right side teeth were not at all touching. So all the cases which we did was with the same method which I've been emphasizing since last 2 webinars. So usually what is my method is we place implants in premaxilla and in intermental foramen, and we avoid cantilever by placing pterygoid implants or zygomatic implants if required. And in the lower jaw, either we engage the implants into the cancellous bone or lingual cortical engagement or buccal cortical engagement, wherever the bone is allows us. Okay, so that's how we avoid totally cantilevers in upper and lower jaw. That's the most important aspect. So this case was done with the QuickDent cortical TPR implants. Okay, so with minimum drilling, you can just place this implant because they are super active implants, and I just love it. They have a crystal polished, so it can overcome the periodontitis or a peri-implantitis related issues, future crestal bone loss if any chance is happening, still that can be really controlled. And it is conducive to engage the basal cortical bone, so immediate loading is still possible, okay, in majority of the cases. So whatever cases I'll be showing you will be using these 3 particular implants, that is zygomatic implants, the TPR implants, and of course the OSSI, that is a standard conventional implant. All these implants were used to show all the cases which I'll be doing. So this case, technically we started, and so what happened in day 1, we did the extraction of all the teeth, we placed the implant, placed the multi-unit. Now we did this case with a conventional method, that is analog method. We put the open tray impression post, and then we splintered it with the help of pattern resin. We cut that pattern resin, and then we checked for a zig trial also, whether one screw test. You can see on the x-ray, none of the impression post or a mu transfer is lifting up in the x-ray. If it is not, and only one screw is attached in each jaw, if the one screw is not positive, then definitely your prosthesis will be active. And after this, we take this hassle, impression, which is very troublesome for the patient. Everything is filled up with the impression material. So that's how we used to do before. Okay, so, and this goes to the lab. We also take day 1 something called primary bite. So this could be either on any vertical stop. So this could be on the healing abutments, and then this is sent to the lab. That is nothing but a temporary or a tentative jaw relation. Okay, now what lab will do on this particular bite, okay, he will make a screw retain record base. Okay, if the space is good enough. For example, this patient have a moderate interarch distance, so space is good enough. So screw retain record base, that is 2-piece record base is there. On this record base, he will make a teeth setting. Am I right? So he'll do the teeth setting and he will send us to us. At the same time, in the lower side, you will see the jig verification. So we will also recheck whether what impressions we have taken is accurate or not. And we will recheck the jig in the patient's mouth. Again, if there is any lifting of one screw test is happening, we cut that and we again rejoin it. And we again see in the x-ray, all the multi-unit are sitting accurately and only one screw is attached in each of the jaw. You can see that unless if it is done, you will not get passive prosthesis. And believe me, if you want to have a success in screw return prosthesis, then the passivity is the most important aspect. You have to do one screw test. Okay, so this is what we do on a day 2. On day 2 also we do the teeth trial verification. That is, we will do the teeth setting trial. This is something which you do on the denture. Okay, once this is done, if any adjustment is needed to change the teeth positions, we can do it because this is wax trial. Okay, so we do it and we send it to the lab. Lab then re-scan this with extraoral scanner. Now this is not a digital, but then this is done in the laboratory. He will scan it with the extraoral scanners, and according to that, he will get an idea and he will do something called cutback technique, where he will reduce the thickness of the for the ceramic, and he will print the metal, that is metal framework. And this is nothing but what we called is a framework trial. Again, we will check with a one screw test whether everything is perfectly fitting or not. That is something which we will do on a day 3. This is called framework trial. That is how we do it. Okay. Now, on day 4, again, we'll take the bite and we usually send them for the ceramic layering. It comes to us. We check again the passive fit. See how many x-rays we are taking up. Okay, this is again the third x-ray. We will be checking the passive fit of the patient. This after everything is okay, then we will do the occlusal adjustment and all fine. And we will be sending this to the glazing. Am I right? So this is how we will define the processes. So she was having excessive vertical and now we got an ideal vertical for her. And this is 2-year follow-up of the patient. Everything is fantastic. There is a minor shrinkage which is there in the lower jaw, but rest is all fine and she is absolutely comfortable with that. So this is how we used to manage the spaces which is having a limited or a moderate interarch distance. There are certain cases where it is impossible to have a good amount of space in particular jaw, maybe because of the bone is there. So in that cases, it is impractical to have a screw retained base plate. So we don't use screw retained base plate. Rather, we just take the bite and we ask for a wax print trial. You can see this, and that's how we adjust the occlusion and then we replicate that to the final. Clear? So this is, so your interocclusive material will vary depending upon the interarch distance. So here, suppose you don't have access to wax print. What some technique previously the technicians used to give us with this all teeth with resin, pattern resin. This is a pattern resin with plastic sleeves. Okay, so this is also another options you can do where the lab are not at all digitally equipped. But today, like almost all the cases, all the labs are very well equipped. So you can see this is used for transformation of this patient also. I'll show you another case where there is a sufficient interarch distance is there and super periodontally compromised dentition. Okay, so this is removed. Day 1, you can see all periodontally hopeless dentition. So we removed everything. I'm not going in detail about the surgical aspect. I've already showed you how we place it. So this is after the placement with an X-ray, and this is healing abutments placed on the implants. And on the same day, we do something called open tray transfer impression, that is manual impressions. Before that, we check for jig verification at the same time, so that we can avoid the time. Here in the upper jaw, we used total pattern resin with the floss, and lower we use something called metal bars. Okay, so to just check which is giving us the best result. To my knowledge, both results are good as long as you know how to check the one screw test. On day 2, what we get from this thing, we also send the bite to the patient, to the technician. On day 2, they will give us something called metal trial, and on this metal trial, he will make teeth setting, okay, which will be removable. Okay, now we will check metal trial, we'll check whether the fit is perfect or not. We'll take the x-ray, everything is okay, no problem. After this, we will also check the teeth trial. We will do minor modification in teeth setting, whether the teeth canine is up, canine is low, and all these things. That's just like what you do during your college days. In second year, you used to do teeth setting. So these minor modifications you do in the patient's mouth, and seal the teeth, and then this is sent to the lab. Now what technician will do? Technician will overlap this, and he will scan it. According to the scan, now what he got is the position of the teeth. Accordingly, he will do the designing and he will print it. Now this is not printing, this is milling of the superstructure. So it is called shell. So this shell could be of any materials, okay, like HIPC, it could be reinforced PMMA, graphene, anything. And on this particular day 4, what we will get is the shell trial. Okay, so on this bar we will put this shell and we will do something like jig trial. Now why we are not giving, now this is different from metal porcelain. Metal porcelain, the procedure was different. I'm showing you something called hybrid. Okay, why I didn't prefer to go for metal porcelain? Because the teeth will be very heavy, it will be loading the implants too much. So we went with a lighter version of teeth, and that's how we got the final process of the patient. Okay, so everything is screw retained. This is the before and after of the patient. So if was what we used to do 4-5 years back. Okay, this is the almost 4 years follow-up of the patient. It's fantastic. Now what happened in analog method, we have to do manual impression. So it's not easy. In order to take one impression, it takes around 15 minutes for experienced person and maybe around 30 minutes for a newbie, right? It's not very easy to take full mouth impression, especially the 6 implants are there. 4 implants is still more easy, but 6 back into the pterygoid, it's not very easy. So attach and then cut it and check verifications and have jig verifications, whether it's open or not, again re-verify. It takes time. So manual impression is the most important concerns with the analog method. The second thing was the manual bite. You have to take the bite and you have to take the impression, and the physical delivery used to happen to the laboratory. So a lot of time used to get invested. Lab person have not come, and then you're waiting for lab person, and you have to finish the case in 5 days, and he will come in the evening. So you have to a lot of dependencies there. Another thing is mock-up trial is also done when the technician is doing everything is on the articulator. He is not having any relationship. So mock-up trial is also with manual method. So this is what used to be the results of analog method. So how we do today digital way. Let's see. Okay, now suppose something similar, patient periodontally compromised dentition, lot of teeth were mobile and having deep pockets, so we decided to go for total extraction. So day 1, what we do now is we do complete intraoral scanning, upper lower jaw with the bite, everything is done. Now we go for surgical extractions. Okay, we extract and we place the implants, multi-unit is attached, everything is okay. All these are the TPR implants from QuickDent. We attach the QuickDent scan body, that is multi-unit level scan body. They also have an implant level scan body, but when you're using multi-unit, you have to use multi-unit scan upper and lower jaw precisely. Okay, and at the same time take the bite. So now how we take the bite? We take the bite on the multi-unit scan body itself. Okay, and then we recheck it, we scan the bite. Now what moment we take the bite, okay, there are certain softwares in the advanced scanners where the bite gets automatically recorded. Okay, so it gets recorded, and you can see in the lower this thing here the bite is totally recorded intraorally. We are not sending any physical bite to the technician. We will be sending these two things: pre-op scan, we will be sending implant scan, and as well as the bite of the patient. Now what he will be doing is he will be overlapping the implant scan over the pre-existing teeth. And that is on certain softwares which they have, that is Exocad software. And after that he will be designing a complete set of new teeth. Okay, that is all thing is happening, and what a complete set of new thing is designed on the basis of the patient pre-existing records. Okay, everything is designed. He will print it. After printing, he will send it to us, and then once he send it to us, we will re-verify it. And this is nothing but a digital mock-up trial. I hope you got this. Here no teeth setting is done, everything is printed. So once digital printing is done, we will see whether the now patient says the teeth are quite huge. Actually for me it was perfect, but then according to patient he wanted a little narrower teeth, so we took and he stressed on that, so we too did that. And after this, we did the modification. According to that modification, metal trial were printed. We also did the metal framework trial. This procedure is the same. Metal trial, how you do it, you'll do the jig, you'll do one screw test, fit verification, x-rays, everything is the same as the analog method. Okay, so it's like you doing digital and you're coming back to analog method, digital and you're coming back to analog method, right? So this is done. We take the bite, and this bite we send to the technician. Why? Because for ceramic, there has to be physical mounting so that they can build. Okay, it is not milled part. Anything which is milled, probably sometime you don't need bite at all. You'll see in few further cases. But here, definitely some building is there. So definitely the mounting is needed. So here, the first time we will send the physical bite. Okay, and then patient, they will send us with something called BIS trial. Now incisal height was a little less, so we added certainly a composite to give them guidance that we need to add this thing. This is a little shorter, and this is the final prosthesis, and this is how the patient is final. Okay, he wanted all the shades and all these things, and a little narrower teeth. So this is the final of the patient. And you can see the final prosthetic OPG of the patient. Everything is fine and fantastic. She is absolutely happy now. Okay, so that's how we used to do for a totally compromised dentition where majority of the teeth are present and they are in decent alignment. Now, the case where the teeth are totally absent, the problem with such cases is if you do flapless surgery, you are not in a situation to understand whether your implant, this is the sinus anterior wall, for example, whether your implant is in, you will do the osteotomy in the sinus or you have to do anterior to the sinus. Sometimes it is not easy. So this case, peso also we did, but we did with the guided approach. Okay, now but not guided, fully guided, but pilot guided. Now what is the difference between pilot guided and fully guided? Pilot guided is means with the guides, when you place, you will do only one drill. Only drilling is possible. Okay, after that any sequential drill is you have to do, you have to remove the guides and you have to get, so you get an orientation of the direction, but you will not do the complete procedure. And what is fully guided? That means all the drills you will be doing it. At the same time, you will place the implants through the guides also. Okay, that is fully guided. Now, because the TPR implants are long enough, like 25, so I'm not a big fan of fully guided because right now it generates huge amount of heat, and if you're placing a longer implant, so I prefer to go ahead with the pilot guided. So I'll show you cases with the pilot guided surgery. Okay, now say this example, for example, this case, totally edentulous. Day one, what we will do is we'll scan his upper and lower edentulous jaw. We will get this data. This STL is sent to two people. First is to the guys who are going to create the guide, and second is to the laboratory, dental laboratory, who will be fabricating the teeth. Okay, so once we send it to the guided technician, he will correlate this thing with the software of and the CBCT data, and he will prepare a guide. Now, because this is a soft tissue, so we will also send the so he in this case he made a soft tissue guides. Okay, soft tissue supported guide, and what data which we get on day one, it is also sent to the technician. He will print the model. On that model, he will make a record base, right, along with the wax rim. So day two and the second visit. Now, second visit, we will be checking the JR, vertical, ideal vertical, and centric, and everything will be recorded. All central line, just like what you do for the denture. Same thing is recorded. This step is being transferred to the technician. He will design the teeth on this particular information, and he will make a mock-up denture. Okay, so what is mock-up dentures is nothing but this is having all the palatal coverage, everything. It is like a denture, but access holes are there. Okay, now once, and we will re-verify it with the in the patient's mouth. This is a edentulous mock-up trial now. You got my point? So this is edentulous. Now I've still not started surgery in this case. Mock-up trial is ready. Everything is okay. We will check. If there is any bite discrepancy, we will correct the bite discrepancy. We'll record the bite and we'll send it. Once this send it, they will rescan it extraorally and they will now replicate this all parameters and informations and they will print. Now this is the transitional teeth of the or a prosthesis, which is a shell. Okay. Now this shell is ready and your guide is also ready now, tissue. So this is on day 4. Day 4 before the surgery, these things are ready. Now what we will do, we will attach the guides into the patient's mouth. As I've said you, this is a pilot guided surgery. Okay. So not the fully guided. So the fully guided means from that implant can also be placed. But here only we are placing one drill. And then from that we are just placing one drill fast. You can see how fast I am. I'm very accurate and fast. 1 drill, 2 drill, 3 drill, 4 drill, 6 drills, finish. We take out the guide. We check whether we need to do more drilling. If yes, we do more drilling. Otherwise, we straight away place the implant. We measure it and we straight away place the implants. Okay, so we are placing the implants. The left one is engaging the nasal floor and the right one is engaging the pterygoid complex. Okay, so moment we get a good talk. Now, because I told this is a pilot guided, these are not placed through the guides. This is placed after removing the guides when we are placing a manual placement. Okay. In guided, fully guided, we can place the implant through the guide as well. Okay. So yes. And this is the X-ray of the patient, multi-unit attached on the same appointment. Our shell is already ready. We will put the titanium cylinders. This is also called temporary cylinders, and we will make a hole and it will come, we will catch the position of the temporaries. It is done. That is how you do the conversion of the normal dentures. I think many of you must be knowing about this. And now because there will be little bit bite discrepancy, so what we will be doing it, we will retake the bite. And of course, because we are catching it up, the undersurface of the process will be very, very poor. So we will remove it and we will send it to the technician to improve the undersurface of the process and reinforce the processes. Because you see, while trimming and while catching with the titanium cylinder, there will be certain part which will be broken. So there we need to replace. We need to reinforce with the regular acrylic resins. So that's why he on the palatal side, on the lingual side, you can see the pink color resin is there. So that is nothing but he improved the strength of the prosthesis. Okay, now this is delivered to the patient. This is delivered to the patient on day 2. So this is the process. On day 2 of the surgery, patient is receiving a transitional prosthesis. This is the X-ray of the patient. The only thing where I am worried about is this is not having any metal inside it. So there is a chances if your prosthesis is not strong enough, it breaks, it can jeopardize your implant. That's why always send it to the technician on day 2 for reinforcing the process to make it more thick, add more bulky material for the 2 months at least, so that it doesn't break for 2 months. And compulsory after 2 months you have to change it. Now, how we change it? Patient comes with the shrinkage of the gums. We same way we record the upper and lower jaw, scan and bite. Okay, and also after retrieving the prosthesis, we will record the position of the multi-unit and the new position of the gums. Healed areas, healed gums. Everything is recorded. Now we will send this data to the technician, and technician, this is how he will match. See, these 2 data he will match, and he will on the scan body, this teeth is recorded. According to that, he will now make a metal trial and he will again prepare a shell. So this is a metal trial of the patient, and that's a shell. This is not too attached. So we will attach it separately in the patient's mouth and we will do the occlusal adjustment. Everything is okay, no problem. This is just to show where the pink color should come, and that's the final process of the patient. So you can see the transitional, how it was before, and definitive how it is now. So because the interarch distance is good enough, that's why we decided to plan the case in this manner. Clear, this is the final visit of the patient, and that's where he's getting the final process. So patient is basically getting his teeth on day 2 of the surgery, and I think after 2 months, in another 2 visits, he's getting a final processes. But then you have to do a lot of homework for such cases. Okay, so that's day 1, day 2, and after 2 months of the patient. Well, you can see the X-ray also. After 2 months, this is the processes. Now the final process is having a metal frame inside nicely. It will be longitude, and the results will be fantastic. Let me show you another case where we are doing guided as well. The bone is not stable. At the same time, if you see, the bone is resorbed in the posterior area, and not all the teeth are present. Unlike previous first digital case where all teeth were present, right? Here we need to do certainly some kind of bone reduction also. So what we designed in this case was a stackable guide. Now, what is stackable guide? I'll come to that. Now, this is the pre-operative situation of the patient. Same way, we recorded everything and we send it to the ExoCAD. They got this data. Okay. According to this particular data, he made a digital mock-up. You can see the digital mock-up in the lower aspect, and superimposition of the old data with the new data, and then he made a digital mock-up. Now you can see how we make the stackable guide. Now we need certainly the bone reduction in the premaxilla and the mandible. So we made a guide which will be called a base guide. On this base guide, okay, there will be another guide which will be sitting, which is called stackable guide. This will sit on the base guide like this, and so here, okay, now this is how you will get, and on this base guide, on the base guide, when the stackable guide is fixed, you can just do the drilling directly. Okay, the one other advantage of the base guide is that on that it can fit your pre-milled teeth as well. So for example, whatever data we got from the pre-op of the patient and the digital mock-up, we will send it to the guy who will fabricate this. He will put the screws which will be fitting into the base guide, and he will fabricate the teeth. Okay, so technically this kind of teeth will be ready and it will be fitting on the base guides. Okay, so let's do that and see. So this is day 1 of the premaxilla, where we attach the base guide. Over that we reduce the bone, and you can see on this side how we are placing the implants. Here also lower mandible, same way, base guide, reduction of the bone, and then attaching this stackable guide and doing the drill, pilot guides. Okay, this is done. So that's how, and this is after removing the guides, we do the placement of the implants after doing necessary drilling. Now implants are placed, multi-units are attached. Now here we have not got the access holes because we were not sure where the multi-unit position is going to be. Okay, although the implant position was perfectly sure, but then so we decided to and sometimes it weakens the processes. So we decided to take the impression of the multi-unit level. So what we did, we attached the multi-unit on the patient's mouth, and we used the your rubber base putty, and we just staked this processes onto the base guides, and we got the position of the multi-unit. Now this is sent to the technician will make a hole through this. Okay, and also we have taken the standard digital scan for the upper and lower jaw. He printed the model. On this model, he now nicely prepared the access holes. So there was nothing was compromised. Everything was good. And see the positions, respectively positioned, and that's how he defined. He made the processes with the undersurface absolutely conducive for the good hygiene. This is the patient on day 2nd. You can see before and after. Now it was a time to, after 2 months, how we changed it. After 2 months, when again same way we took the scan of the patient, with the teeth, with the bite, and after retrieving the teeth, again we took the scan of the multi-unit position and of course the current soft tissue profile. All these things were recorded. These two data were sent to the technician, and with this particular data he fabricated the final process. Of course there were 1 or 2 more visits like last patients, the same were used. Okay, now this is the final of the patient. This is the final x-ray of the patient after 2 months. Now I'll show you one more case where the bone was absolutely thin, but here in this case we didn't do delayed loading. We didn't do immediate loading, but we did delayed loading. But yes, how we did here, we didn't use any kind of guides. You can see the bone after reflecting, see the thin bone. Because the bone was thin and also the soft, it was soft in nature. So we decided to wait for a certain period of 2 months, and we place TPR implants. Placing of standard implants or rough surface implant would have called for grafting. So we avoided that. TPR, usually expands the bone. Well, you can see this width is almost 3 millimeters or maybe 2.5 millimeters. The drill itself is to 1.5 to 2 millimeter. So the bone is almost equal to that. So maybe around 3 millimeters. This is implant is been drilled over there. So width of the crest is 2.5 millimeters. We place 3.5 by 16. We measured it. The length goes to around 16. This is called depth probe, which is most important aspect. If you're doing bicortical fixation, you need to measure the length. And that's how we are placing implant. One of my periosteal elevator is holding the bone so that the bone doesn't fracture, and I'm placing it very softly. You can see slowly I'm placing, not exerting any extra forces on a buccal bone. And our direction of insertion should be similar to the direction of osteotomy. If you change the direction, you may lose the torque, because in soft bone you may tend to go towards the softer bone, the softer wall, I would say. So in palatal and labial wall, the labial wall is the more softer wall, so you tend to come out of the labial side instead of palatal side, and I would drill this towards the palatal side. So you can see in such a thin bone also we could place cortical TPR implant, because this implant itself worked like a bone expansion screw. Now because the torque was not amazing, I would say, but maybe more than around 40 NCM, but not amazing. So that's why we decided not to take a risk, and we just put the cover screw and close and send patient, and it is a delayed loading. So I always say, immediate loading is not a ego, it is a science. If you can definitely help, if it can definitely help the patient, then do it. Otherwise, you should not take a risk. So this is done with the delayed loading, engaging the nasal floor everywhere, but the bone is soft, unfortunately. It's a D4 bone. After certain period of time, say around 2 months, everything, healing abutment, everything is attached, and we are taking a scan of the patient. Lower tooth are very well prepped. After, on the scan body, we put the alu wax and we take the scan of the patient, and this scan has been transferred to the into the scan machine. Okay, so you can see this is the scan which is recorded, and so physical digital bite is there with us. Now we are not taking any manual bite. Now this wax is in my clinic, it will not go to the technician. This digital bite is transferred to the technician. Now he will get upper and lower jaw scan and upper and lower jaw bite. On the basis of that, he will fabricate this teeth. We will not send anything physical to the technician. On the basis of he will send us this next day. Okay, next day he sent. Now what we thought, the teeth are very short, so we will add certainly some composite just to give them a guidance that this should be the projected length of the incisors and the lateral incisors. Everything okay. Now this has been sent to the technician. Here also we did the scan and we send it to the technician. All fine. He just made the metal trial according to this. Now here, that's where after the metal trowel, we'll take a real bite and physical bite, and now we will send, because that's where he have to mount and he have to do the ceramic layering. So metal trowel you cannot send without bite. So we send it, and she was having a concern, extra concern about the lip drop. So we added a little more thickness, because see the bone loss, because of the bone loss, the bone is located quite more palatally, because the maxilla shrink inside. That's why the bone is there and the teeth position is comparatively outside. So that's why we had to add little more bulk on the cervical aspect, so that her lips doesn't get dropped. And this is the bite of the patient, upper and lower. Now lower, we decided to go ahead with the individual crowns and bridges after doing a root canal treatment and whatever. No, I think no root canal was done, but then we adjusted the plane of occlusion and every single crowns was given. So it is basically an FMR case. This is done, and here this is the final of the patient, before and after. So you can see her lip was getting dropped in the pre-op, but then after in the finally she got a very good lip support also. So that was one more case. Coming to another case where 4 implants, wide body implants were there, but unfortunately one implant failed, and because of this there was a cantilever which resulted into breakage of this prosthesis. So I am not a big fan of cantilever, because this is a common problem with the cantilever. You can see the pre-op fractured prosthesis. So what we decided to retrieve this. Anyways, this was a zirconia. Although the connector thickness was great, but still the cantilever doesn't work even in PFM sometimes. It can fracture if the cantilever area is in contact. So what we did, pre-operative, intraoral, we scan all, upper and lower, everything. Okay. Everything is ready. Our record is ready. Our bite is ready. Now we'll take out the prosthesis. We will add more number of implants. Like 4 implants were added in between all these implants, and definitely we gave the pterygoid. Although the pterygoid was very difficult in this case, but yes, it was having a decent junction where we could engage the pterygoid. We got a good torque and we placed the pterygoid implants. So we avoided the cantilever. We scanned everything, and we didn't send any physical bite. And next day, what we got is the teeth trial, because what he was having was first information of that was a pre-op scan was there and post-op implant scan were there. He merged that, and according to the pre-op scan, he made the new teeth, and that was nothing but the wax print trial. So mock-up trial is there. We will check. We checked, and we, as usual, whether the incisal height was not appropriate. So we added certain composites and made the mock-up. This mock-up is ready now. We now scan the mock-up and send it to the technician. Technician, according to this particular bite, he will make a metal trial. Okay. The metal trial is there, but now he is having the idle vertical, because the pre-op was having an idle vertical. So his whatever he printed was at idle vertical. Okay. So here we avoided taking the bite. So we just send this back to the technician, and he did everything on the pre-op bite. Okay, vertical. And he sent us the final process on day 4. This is the day 4 final process. This is the patient's. He was being very happy, because he got the posterior teeth to achieve. Initial, you can see, I think 2 teeth were on the left hand side was giving him more advantage over the previous prosthesis. And this is the patient with the fractured teeth, and after receiving the final prosthesis. So he was having more, he wanted something more curvy teeth or something. All his desires were, whereas pre-operative it was a zirconia, but it was all flat teeth. So all these requirements were taken into consideration. So my friend, you understood about the analog method, also about the digital method. So digital method is just not about the intraoral scanning. It is about the planning before the surgery. You can do the guided, you can go fully guided, you can go pilot guided also. We are doing fully guided. So we will be coming up with more and more cases shortly with the fully guided as well. So guided is one aspect. Then second aspect is a digital impression, because it is a hassle free. It takes decently less amount of time with the new scanners, advanced scanners. And the best part is, you don't have to put all the big tray into the patient's mouth, and after surgery the patient is already uncomfortable. So this also helps us a lot. And of course the accuracy of the digital scanners have improved a lot, but definitely it's not that it is 100% accurate. So you need to do a jig verification even if you are having a digital scanners, a digital bite or digital impression you are doing. The jig verification is the most important aspect, because it is just not the scanning, but it is also about the printing, which can create an error. For example, some printers may print little with a shrinkage. Some printers print with become the print, it instead of shrinkage it loosens. So things can go wrong. So it is better to verify it in the patient's mouth on day 2 or day 3, whenever you are having. Another advantage is the many a times you can do a digital bite. Your delivery is not physical, but rather it is Wi-Fi delivery. And of course, you can use a digital mock-ups. So that's more important thing, over compared to the manual mock-ups. So digital mock-ups is more easy. You don't have to worry about this thing. So if we come to analog and manual methods, there are advantages of digital methods in some aspect, but in every time we have to come back to the analog method. For example, jig verification, this is a very important step. Metal trial, all these things. So unless you have a thorough knowledge about the analog method, you cannot jump directly into digital method. But digital method is one of the adjunctive, but it cannot replace the analog method. If suppose there is any error in your scanning or in your printing of your models, there is a chance you have to repeat back with the manual impressions in the patient's mouth. So you're coming back to the analog method. So if you think that I don't have anything and I'll just learn a digital method, it's not the way. So digital and analog method basically goes hand in hand. In analog method also, if you see now, many labs are very well developed. Even if you are doing everything manually, but moment is go to the lab, they will scan with the extraoral scanner. So that is also, they also, a part of analog things, part of digital is always coming, even if it is analog method. If you're doing DMLS processes, it's nothing but a part of a digital, right? So it's not just particular method is the best. Both method works in and hand in hand, and that's why you should have the knowledge about analog as well as digital method thoroughly and completely. And this is what is the secret I was going to tell. Both, you should have a knowledge about both the aspects. It's not about that. So with this, I would like to conclude my presentation. You will see such more of cases on my Instagram. I would like to thank QuickDent Implant System for their immense support. The system is available pan India. This is a scan code where you can scan for the brochure. That's a Mumbai central office. They are having service all over India. I'm very happy and very fantastic implant is there. And I would like to thank Dentist Channel Online for this webinar, for this opportunity. I would like to thank Dr. Shriya, Mr. Melvin, and Mr. Siddiqui also for the immense support. With this, I would like to conclude my presentation. Thank you so much.
Thank you so much, Dr. Mayur, for again such an insightful session. So let's talk about the Q&A session. So yeah, we have a couple of questions here. So yes, first question is from Dr. Kostavkar. In between trial and implant, I think he is going to ask, in between trial and implant, there is some orange material. So what's that?
That's a bite registration paste.
Okay.
It's a bite registration paste. You see, it all depends on your interarch distance. If the interarch distance is minimum, you use bite registration paste. If the interarch distance is too much, you use wax. A wax could be a alu wax or a red wax as an interocclusal record. It's an interocclusal record. Yeah.
Okay. The next question is again from Dr. Kostav, that base guide are by, I think he mean to ask that from where we can buy base guide.
See, base guides, I think you can, for base guide purpose, you can connect, like I get it done from Dr. Ramiz. He is from Hyderabad, and he is also one of the with us in the QuickDent. So you can, if you want, you can just text me on online. I will give you the number. That's not a problem.
Okay. Next question is from Dr. Nirali Agarwal. Good afternoon, sir. Which scanner do you use for this? And there any stitching error?
So stitching errors, I use Prime Scan. It's not about the scanner, but more important is about the technique. You know, so if you're doing a surgical post-surgery scanning, blood is there, so there is definitely certainly some error may happen. That's why you should do scanning after proper hemostasis first of all, and stitching error is more common in the mandible. So if you have to do it in a one go whenever possible. So I think all good premium, good segment scanners today, this error has been almost eliminated. Not a problem.
Next comment is from Varun Kashyap. Nice
Thank you.
presentation.
Thank you, doctor.
Okay.
Thank you, doctor.
Next is from Dr. Hemang Haldaria. If patient had placed different companies implant like Ostium and we placed different companies implant like Norris, then how to connect all implants in maxilla or mandible because all companies screw abutment analog are different, and how to improve these type of cases and how to decide cost.
I understand your point. See, Dr. Hemang, this scenario will happen only if patient have got certain implants from some another doctor, and then it's coming to your clinic and you're placing, other system. So you have to buy the respective components of the particular system. There is nothing hard and fast. You can join any two-piece implant to any other company's two-piece implant. That's not a problem. The problem is when you're connecting one-piece implant to two-piece implant. So here you have to do only one thing. You have to call the representative of the particular company and buy the respective components. That's it. Or else ask this components from your friend. That's more easy. I don't think so that's any problem to connect two different companies. But you should not use other company's component in other company, another implant. That's something not recommended.
Yeah. Next is from Dr. Priyanka Shah. First session was missed. Is there any recorded video of the? Yes, definitely, Dr. Priyanka. If you are Prime member of Dentist Channel online program, so you will get the webinar and you can watch the recorded video. So it
Yeah.
is available only for the Prime members, so you can join it there. Next is from Amit Gilani. Please speak something about different material options in prosthetics, like when HIPC is preferred, etc.
So different prosthetic options. Whenever the I told already this thing. Whenever the inter-resistance is less, go for a gold standard, that is porcelain fused to metal. Okay. Whenever the inter-resistance is moderate, you can either go for porcelain fused to metal or a hybrid option. Hybrid means two different material, that is metal inside, and over that there will be some kind of either the teeth setting or some kind of shell. Okay, I've shown you. And if you have absolutely inter-resistance which is too much, in that case never go for PFM. That's not a gold standard. It will be very heavy. Instead of that, go for either the titanium metal bar, and over that the prosthesis, or you can have a cobalt chromium bar over that the shell prosthesis. So that is nothing but HIPC. So you should go for that.
Next is from Bhagyashri Misal. How should one kickstart their implantologist journey? Your recommendations.
So today the only problem is in India is, we learn how to place implant. You should learn how to sell the implant. So you start learning all those things. I think you will solve your problems. You start learning how to sell the implant, and then you will get more patients so that you can start learning more and more implants. Okay.
Yeah, means I think to establish the good rapport between the patient and the clinician. Apart from that, the way you tackle and the way you manipulate the patient.
Absolutely.
Yeah,
So or else get associated with someone who is doing good number of cases, learn from him, and that's how you should do. Have a good mentor. That's another option.
yes.
Drilling angulation should be.
Next is Dr. Kostavkar. Drilling angulation should be 30 to 45 degree.
35 to 40 drilling angulations depends on you totally. It you can place 0 degree, you can place 17 degree, 30 degree, 45 degree, no problem. Okay. In zygoma cases, you can do 52 degree and 60 degree also. It all depends on, bone anatomy and how you're placing. But what is my opinion? Whenever possible, 45 degree is used either in the anterior maxilla to overcome the access wall on the palatal side, okay, and sometime in the pterygoid. Rest areas, I don't think so 45 degrees use. It is more than enough to have 17 and 30 degree for rest of the areas.
Okay. Next is from the Atul Goyal. Is it compulsory to load TPR implant in 7 days like BCS?
Well, I told you already, if we are getting a good torque, okay, a collective good torque of all the implants, then we can load the implants, no problem. But if we don't get the torque, and if the implants is still in the bone and the bone is very soft, you put the cover screw, close it. You don't have to load it immediately. What you mentioned, the BCS is a single piece implants. There you cannot close it. Yeah, there you have to load it. It's like one way journey, one way road. You cannot take a U-turn once you use single piece implant. Here, if you are in a risk, put the cover screw, close it, open after 2 months. I showed you one lady. So you don't have to satisfy the ego of immediate loading that time. You just go with the science. Let the osseointegration happen with the time. Now bone will form there nicely. Yes.
Next is from Amit Gilani. Earlier, they used to say scanners are not reliable in full mouth implants.
Scanners are not reliable. Yes, because nowadays new scanners have come with a much better treatment results. And previously the scanners never used to give a desirable results, especially in the surgical areas. Okay, they never used to show a proper, wherever the blood was there, there used to be stitching issues and so many things used to happen. But now, because I'm using a good scanner, and of course, so these things have become significantly less. In last 2 years, there has been tremendous change in the digital scanning
True.
protocols. A lot of
Yes.
updates have been there.
Yeah, as I observe here, some patients, I think in Korea also, they use like all kind of digital thing because they're so advanced here.
Yes,
So this is not a problem. Like scanners, it is not a problem anymore.
absolutely not a problem. Absolutely not a problem.
Yeah. Next is from Sonali Nalavade. Hi, what material has been used for surgical guide through lab?
Hi, Dr. Sonali. So, this surgical guide materials, it depends. You can get a surgical guide made out of metal, that is cobalt chromium. Also, you can get it frame. You can get it milled out of the resins also. So, which resin is used? I think they are all biocompatible resins. I don't know the name, but then the lab. These are the same resins which is used for digital mockups, but their strength is quite good enough. So you should have, the lab people are the right person to tell you this thing.
Next is from Niranjan Ramachandra. Great webinar, insightful. How much minimum inter-arch distance is acceptable?
So minimum inter-arch distance. So you should, if you are doing FP1 prosthesis is 12 millimeter in one arch and 12 millimeter. So minimum at least you should have 19 to 20 millimeters. It is a minimum, So if you close your mouth, or the distance between their your inside this margin, the incisal cervical margin of the central incisors and the cervical margin of the lower incisors, it's almost 18 to 20 millimeters. So that's the minimum distance.
Okay. Next comment is thank you, sir. Okay. After that, the next one is what from Vatan Jain. In fully guided implant, can we have to worry about angulation?
No, fully guided implants, it itself design, the guides are designed in a way that you can design your placement according to the requirements. You can place it at a tilt also, you can place straight also. The only thing one of the disadvantage of fully guided is, there is a tremendous heat generation because you're drilling, and you're drilling at high speed. So fully guided in dense bone creates massive failures than a normal bone. So the bone get too much of heated. So that's why you have to do in a pumping motion. So many things are there in that. So fully guided, that's one disadvantage. So I recommend fully guided with a drill which are DLC coated. DLC coating reduces the heat. So that's one thing. But then you have an option to always do pilot guided. It's little less expensive also and more accurate. Yeah.
The next one is from Dr. Kostovkar. I think he wants to ask that for pre-planning, which software is preferred, like
So
ExoCAD
you can
only?
use Exoplan, you can use Real Guide, you can use Blue Sky Bio. These are three softwares can be used for pre-planning.
Next one is from Ritesh Kumar D. Tell me about printed tempera crown or PMMA crown, and which 3D printer is best for temporary printing.
So I don't know the name of the company of the 3D printers. I think the lab people are the best people to guide you on this. But then see, this Densplay, they're coming up with the scanners which claim that they are the best. And Signing 3D, they claim they are the best. So you have to decide. This is something you should discuss with the lab people.
Best book can you suggest for clinical knowledge about
Opa
implants?
Carl Mish, read it thoroughly. Carl Mish.
Carl Mish, right?
Yeah.
Yeah.
Should be on
Next one
tip
is
of the tongue.
yeah. Next one is from Hemang Haldaria. Ma'am, my certificate not send me on 27. Oh,
Will
so
be given to you.
yeah, sure. You will get it. Not to worry. Okay, we will do it. Next is from Amit Gilani. They say feedback of hybrid processes is not good. What's your experience that it soaks moisture, etc.? How much it lasts?
So hybrid processes, usually what you're saying can happen in cases where on the metal bar the teeth setting is done and with the wax up, and then it is acrylized into heat cure resin. Okay, so that's a different way. But however, here what we have shown you is two different material. The one is the metal which is printed through DMLS, and another is the shell which is milled out of the material. And these are two different things. So chances of this absorbing and all these things will be minimum. I don't think so. That's a problem. The only thing disadvantage of the hybrid is if it is not well polished, it can stain comparatively more than the PFM. That's why I always say, whenever possible, PFM is the gold standard, and then you should go for this lightweight options. Why lightweight options? Because it will not induce the weight itself. Any heavy weight itself acts as a force on the implant. So whenever the bone is resolved, go for a lightweight. But lightweight disadvantage, it may stains comparatively more than the PFM. That's it.
Next question is QuickDent your company?
No quick. Yeah, okay.
Can I buy as website cost or give discount webinar special offer by
Oh
any
my.
chance? Can you share your
Okay,
contact
so
number?
the most important thing is I am one of the pioneers in this, and cortical TPR is my design. Okay, so there are many more people involved in this. It's not my company, but then I would again tell you something. Website and all these things. Instead of that, you can just connect to the core team wherever you are based. You can put it some message anywhere. That they will connect with you and they will help you to the best. I think Instagram you can message them, so that's not a problem.
Next is some points on how to sell implants well, please.
So that's a new webinar altogether. We'll come with
Wait,
that thing then. For sure.
yeah.
You have to create more success stories, and if you create more success story, people will start believing you. Okay. Patient comes to you, he is interested in what is there in this for me. And if you start saying what you have done, what you are, how great you are, then things doesn't matter. The patient is only interested in what is there in it for him. Okay, you got my point. So you have to focus on that. How to choose.
Next question, how to choose between selecting OS or TPR at particular site?
So as I've told, TPR is more commonly used for more resolved cases, and Aussie, where the bone is decent enough, you can go for Aussie. For single tooth restoration, especially molars, Aussie are the best. TPR is good for anterior sometime, because sometimes the bone where the bone deficiency is there. Aussie can be used also in the anterior, so no problem. Where the bone is absolutely healed and nice, I think Aussie is a very good option. There are a lot of people who love Aussie because of their active designs. I mean, this is fantastic. Yeah. So
How to sell implant easily because patient had too much fear of surgery?
if they have a confidence on you, they will not have fear about anything. So it's about how
Communication
you,
skill.
how you portray this. If you tell we will do implant surgery, then he will be afraid, right? You say it's a implant procedure. He'll be installing implant. How the word is so it's so soothing to hear, right? installing, like installing a software, it's installing implant. Finished.
Yeah.
You have to just play with the words and psychology of the patient.
Yeah. Next one is from Ritesh. Very nice
Thank you so much,
presentations.
Dr. Ritesh.
Yeah. Next is, sir, can you suggest the best book that we make as a master of implantology?
All the books are best. Whenever possible, read, and keep practicing. That's more important, because reading book is one aspect, and practicing is another aspect. Maximum where you will learn, go and sit in the lab for 2-3 hours. You will see the problem they are facing, and that's where you will learn more. Okay, so I used to do that. That's where you should do. Okay.
Next one is immediate loading with PMMA fracture chances.
Definitely, it can fracture, but that's why I recommend go for more retrievable options, so that any chance if it fractures, just remove it and then replace it. I think we last week we replaced one case where it was fractured on one side, and then we removed it, send it to the lab, they repaired it, and that's the best part of the such hybrid thing is it can be repaired intraorally, or sometime take out of the mouth and then send it to the lab, and they can also repair.
Okay, this is the last question I will be taking. So, Contemporary Implantology is the best book for implant, except all these any other implant book suggest.
You can go for this as well as other book also. Okay, two more
Uh,
questions.
I, yeah. Actually, we are running out of time, so this will be the last one. Sir, if patient has only 5 teeth, 2 in posterior and 3 in premolar and canine region, all are firm, then what is good option? Full ceramic crown on teeth or full mouth implant?
5 teeth, 2 in posteriors, and 3 in premolar and canine region. This is a very hypothetical situation. You have to share X-rays in such situations with us. Okay, and so there is a chances in such situations you may have to do delayed loading also. Where the implants has to be placed and all this. So I think this is a hypothetical situation. You have to share an X-ray, and then that's how we will see it. This sometimes keeping teeth should not make patient chew on one side because of proprioception. So that's something we should always avoid. Okay. So
Yeah.
yeah, I think this is
I
done.
yeah, how much rupees? I think it depends upon you how
It
much you
depends
want
on
to
you.
pay. What
Yeah.
is your reason? Yeah. Most essential armamentarium required for implant placement. You need to buy kit for that, and you need to learn
Yeah.
about the
You should
implant.
go for a master's kit. There is a QuickDent master kit. If you get it, you can place pterygoid, all 5 types of implant except single piece zygoma, and of course the standard zygoma. For all 4 types of implants can be placed. So have the armamentarium, good amount of stock. You will be able to place and deliver. If you have any more questions, you are more than free to connect me on Instagram whenever possible. You can send me a message. So whenever I'm free, I'll just type it down, or I'll send a voice SMS. Thank you so much.
Thank you so much, Dr. Mayur. This whole, 3 day webinar, it was just amazing, and everything I learned, even I also learned about the immediate loading, and because I am also just observing the patients over here, so I don't have much idea about these all things, that how to correlate the things. So
Yeah,
it was
yeah.
really very insightful.
Thank you
So I
so
think the takeaway note can be you can just take these ideas and innovations and incorporate into your dental practice, and it can also elevate and prioritize your just patient satisfaction and clinical excellence. So it will be very good for everyone if you take these all things and put it in your clinical practice.
much.
Thank you so much
Absolutely. Thank you so
everyone
much.
for joining with us, and thank you once again, Dr. Mayur.
Thank you so much. Thank you so much. It was a wonderful session. Thank you so much. Thanks to whole team, and thanks all the doctors for being here on the auspicious day of Republic Day. And happy Republic Day to all of you. Thank you so much.
Thank you, same to you, sir.